Hello, everyone. My name is Eric Alvarez. I am the CEO and founder of Grapefruit Health. I believe my this our deck's coming across. Is that accurate? Okay, great. Thanks, Greg. Okay, let's go ahead and dive in. Real quick agenda here. I want to share, who I am, how I got here a little bit. I think I have a unique perspective on the space that we operate within. The current state, really, as it relates to clinical education and as clinical students are seeking opportunities, our model at Grapefruit Health, some of the results that we've seen, and then would love to dive right into the Q&A. So I started my career, I guess, when I was 17 years old. I joined the military, 2003. So you can do the math on how old I am. But really gave me some great discipline and what I needed. Was never planning to attend college or anything like that. This was a kind of the only opportunity at the time, and so I pursued it, and it opened up my eyes to a lot of the world and what's possible. And so I took my military educational benefits. I went and got a lot of education. I have my undergraduate degree in aviation management. Believe it or not, how did I get into healthcare? Question maybe for Q&A. And then I went to Rush University Medical Center out in Chicago, where I'm born and raised and live today. It's a top 3 MHA program, and I sit on academic adjunct faculty there for a long time. Work with lots of students. During that time, I interned at the American College of Healthcare Executives and the National Association for Latino Healthcare Executives. Learned a lot about the association side, which I think is really powerful in healthcare. And from there, went into hospital operations, ran large teams, service lines at the University of Chicago Medicine and then Northwestern Medicine. About 150 FTEs, 9-digit budgets, incredible experience to show me all the different elements of healthcare delivery on the provider side, understanding rev cycle, patient satisfaction, call center operations, provider management, team management, et cetera. Again, mentioned my role. This will become very relevant here in a second. And if you look at the title of the presentation, right, engaging the clinicians of tomorrow today, the clinicians of tomorrow are clinical students. And so that adjunct faculty role is really how I came up with the concept for Grapefruit Health. And in 2015, I joined a startup. I kind of left the formal side of healthcare and I joined the innovation side. And that startup was in referral management, SaaS. I was the chief operating officer. We grew that company for 5 years and got acquired by Cerner in 2020, which was really exciting. And ever since then, I've been involved in started Grapefruit Health, but also I advise a lot of venture capital firms and PE funds and the likes on all things innovation. So a little bit of a unique perspective here, right? So I was a hospital administrator. I saw the problems in healthcare. I saw the inefficiencies and the opportunities. As a startup operator, you learn how to take really crazy ideas and bring them to fruition, and how to bootstrap and raise money, et cetera. And then the faculty role was where I saw this immediate opportunity and how to tie students in to solve some of these labor shortages. And it's really those three combined that led to the start of Grapefruit Health. And at Grapefruit Health, largely, just to kind of get to the punchline, largely what we do is we employ clinical students to close gaps in care. And in my faculty role, I teach value-based care contracting, and I get a lot of clinical students in that class at Rush. And they're asking me for internships and part-time jobs and all these opportunities. And I was like, we're in Chicago. You got University of Chicago Medicine, Northwestern Medicine, University of Illinois, Chicago Medicine. You have North Shore, which is now Endeavor. You have, it's a wild amount of healthcare, and they couldn't find roles because they didn't have cars and they couldn't work 9 to 5. And their Wednesday is different than their Monday. And every quarter their schedule changes. And then they have finals. And, how do you operate in that environment? How do we get these students involved and give them clinical experience while they're in school that's meaningful? And so that's what I set out to solve. And we'll talk about that here in a bit. I want to talk a little bit about the current state of the clinical student workforce, which is like, wow, that's really niche. But obviously, to do what we do, we had to become experts in this. And so in our early research, we discovered there's actually over 1 million students in the United States today who are getting and pursuing clinical education. And just your typical, bachelor's of science in nursing, your BSN, 270,000 students are pursuing that career. Another 120,000 in social work, 50,000 in PharmD. You add up all the pharm tech and MA and all the different levels of nursing and pre-med and actual med students and dietitians, it adds up to be over 1 million students. And 50 to 70% of them are seeking experience in part-time work, right? So just quick back of the envelope math, that's like 700,000 folks who are looking for work, right? That's a lot, or looking for experience at least. And then if you look a little bit deeper here, 75 to 95% of clinical programs report major concerns over developing clinicians, future clinicians that have enough experience. And at the 95% is the highest, and that's a lot of the APP programs. They're really desperate and they're seeking that, right? Meanwhile, on the other side of the coin, we're short by 3.2 million healthcare workers. Massive, massive workforce shortage. And the things that contribute to that are, one is school capacity. Just in nursing alone, BSN alone, 80,000 qualified students are turned away each year from school. Like, they have the right test scores, they have the right experience, everything's great, just simply because the schools don't have enough spots. Major retention issues in the nursing workforce and the clinical workforce in general. Not to mention retirement, right? The rural healthcare is hit a lot harder by this. It's harder to get folks in there. And then immigration, right? This new administration is really changing the script here on immigration, and that is going to have a profound effect, especially in senior living. I don't usually present like this, so it's kind of weird that I can't hear anybody or see anybody. So I hope this is all coming through. Greg gave me the thumbs up earlier, so I'm hoping it's all coming through. Okay, so here's the big mismatch that we're solving, right? Workforce shortage, short by a ton of people, clinical students seeking experience. They want to come in and help, but there's no infrastructure that lets them do this, right? Now enter Grapefruit Health. That is what we are. We are the infrastructure. We have solved that problem. So here's our model, right? And so because we're using clinical students, this is unlicensed, great, coming through. And because we're using clinical students, they're obviously not licensed, right? None of the work we're doing is billable care necessarily. It's what can a person without a clinical licensure really do, right? And so we decided to focus on care gaps. And that's not totally true. We had to find product market fit and get there. We actually started off in senior isolation and loneliness, which is how we got our name. You can ask me in the Q&A about that. But we settled on this care gap closure because you can do a lot of this care gap closure coordination over the phone, right? And so if you just look at care gaps, only 20% of addressable care gaps are closed every year. This costs the ecosystem $400 billion, which is insane. And over 100,000 Americans, unfortunately, lose their lives due to this lack of care gap closure. And we talked about one of the reasons why it's happening, because huge workforce shortage. So we're prioritizing bedside, highest acuity type stuff. The cost to close gaps historically has been just too high for the current models that are out there. I think certain things are making it better. And then the processes and approaches are not that intuitive. Like, it's not always obvious how to close a care gap and what are the best strategies and methodologies here. And so punchline again, Grapefruit Health, we have about 300 clinical students that work for us. And when you utilize a clinical student, they get paid, we get paid, and it still winds up being about half the cost to close a gap in care compared to a W-2 worker with twice the speed and industry-leading quality. Back to the infrastructure component. Remember the slide that we showed where there's this huge workforce shortage and you have all these people wanting experience and there's no way for them to get it. We've created the only solution for clinical students to work remotely for healthcare organizations safely and totally around their schedule, right? Which is, again, this was a lot of trial and error, I'll say that. We are B2B technology-enabled healthcare services. We are not a staffing firm. No offense to staffing firms, but we're not going to just drop people off at your front door and you have to show them where the bathroom is or something like that. I don't think that's kind of like a 1 + 1 = like a 1.2. Whereas with Grapefruit Health, we are the service, right? So it's 1 + 1 = like 5. This is not a marketplace. We're not like post your job and the students apply or something like that. We are full soup to nuts care gap closure staffed by clinical students. So how did we do it? We had to define the tasks, right? So first, when I had that idea, I was like, what do you mean they can't find work? I was like, well, what can they do? What are the tasks they can do? And we had to meet all of these requirements. It had to be 100% remote because cars and dangerous neighborhoods and blah, 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 blah. It couldn't require a clinical license. It had to be high volume, right? Because we're a for-profit business. We're venture capital backed. It had to be repeatable. It couldn't be, an inbound call center where every call is super unique. We had to have some repeatability. The systems, we built our own technology platform. I'm actually in Florida right now for a conference. And so we called it the Grove because grapefruit trees grow in a grove and there's a lot here. So we call it the Grove. We had to build this system that's now it's SOC 2 type 2, but now we're submitting for high trust. And this is where all the magic happens, right? The students get matched to patients. It's really slick. And last but not least, how the heck do you recruit, train, onboard, manage, and ensure quality for a huge workforce, remote workforce, right? We had to figure all that out, and we have. And so the way it kind of works today is we have about a 1% acceptance rate. Clinical students apply, we evaluate them. The high GPA thing isn't. We don't subscribe to that too much. It's just that we don't want additional work to prevent them, from their grades dropping or something like that. Background checks, we have to do all the reference checks. If anybody here is high trust, you understand how intense it is. And so in order to be high trust, you have to have incredible onboarding processes. Significant training, but not too much. Like a lot of it's self-guided. And then, a portion of it is with our team. And then on the quality side, we match retired clinicians to students, which is really fun. And we'll go through it. Let's just talk about how does this actually work? Okay. So our clients today, we have Optum, we have Centerwell, Humana, MVP Healthcare, Atrium Advocate. These organizations, they tell us which care gaps to close. We're not a data analytics. We're not an Azara or a Arcadia or Healthy Planet. We're not competing with those folks. We get told by our clients which care gaps to close and for who. We consume that data into the Grove, gets brought in, real again, very slick process. The clinical students then log into our application totally around their schedule, remotely, and they click a button that says generate an interaction. They then get matched to patients based off which languages they speak, their culture, their proximity to the patient, what they've been trained on. And then they go through a very scripted process within the application. Hi, my name is, calling on behalf of, confirming your date of birth for HIPAA purposes. And they go through this, they collect data. We can do escalations within there for suicidal ideation, or the patient feels dizzy and they hit their head and they don't know where they are. So those would be emergent. And then there's urgent, where we can escalate the care back to a care team or provider organization or PCP. And then there's just routine, which, we're talking to them about medication adherence and they have foot pain. And so we'll make sure our clients know about it so they can get them scheduled maybe with podiatrist or PCP. And then our retired clinician workforce, which is growing, they log into the application around their schedule and they review interactions and actually grade the students on their performance, making sure everything's safe, et cetera. And if the students ever get graded poorly or below a certain threshold that our algorithm dictates, they actually get locked out of the system and go back through some training. But that doesn't happen too often, thankfully. So what are we actually doing? We're doing, we have, we'll do over 250,000 lives this year. Post-discharge follow-up is very popular. Getting folks in for colonoscopies, mammograms, annual wellness visits, tons and tons of medication adherence. That's a big one, triple weighted. And then surveys and assessments, community health needs assessments, health risk assessments, and SDOH surveys, the likes. We even do Cologuard follow-up and engagement and training and education. So it's really any kind of high volume care gap closure coordination that doesn't require licensure. So why do we think this model works so well? Well, first of all, we have this huge fractional workforce. And again, each clinical student can only be assigned to one program at one client site at a time, but still it gives us tons of flexibility. And a lot of care gap closure and patient engagement has like seasonality to it, or, there was a big layoff or a strike or something happened, Grapefruit Health is always there. And you'll notice this red line is the, I want to make sure we're staying on time here. The red line is the task volume going up and down, up and down. And your team is the black line. The W-2s are there, and they can work 40 hours a week, and they're there to work their hardest, and they are. And then as they've got these giant spikes up here, Grapefruit Health can match them perfectly, 1-to-1. It is a perfect supply and demand match. And the reason why is point number 2. We charge on a per interaction basis, and we pay our students on a per interaction basis. And if there are no interactions, we don't charge. So you literally just pay for what you get. You're not stuck with overstaffing or understaffing. It's completely flexible, which would not work for somebody that is depending on their job for income for their family and their kids and all those things. They need to know that they have consistent work. Clinical students are, it's a very different need or what they're interested in. It's more get the experience and some, walk around money. Third, we're building novel talent pipelines for our healthcare clients. We want them to recruit our students as they graduate. So a lot of HR teams are pretty excited about that. We're helping them do webinars and develop these talent pipelines and get in front of our students. And then we don't require integrations. In my referral management past, I've done probably close to 100 integrations. I hope I never have to do another one, but we certainly can. We do some direct messaging now into the EMR, and we do, bulk uploads, et cetera. But so far, we haven't had to do a true bi-directional integration. And so this is like some basic math here, and I'm happy to follow up with slides. But essentially, Grapefruit Health winds up being about 41% lower of a lower wage healthcare worker. So a W-2 making $20 an hour, we're about 41% lower cost per care gap. If you're talking about a nurse, we are significantly less than, significantly more savings. And then the reason why we can go so fast, again, is we're bringing in folks fractionally for periods of time and comes up and down. Here's a smattering of our clients today, growing quickly, and the results. Last few slides here, and then we have, I guess, 10 minutes for Q&A, 12 minutes. Here's one of our clients in New England. This was with the hospital, Winchester Hospital in New England. This is by doing post-discharge follow-up for them, we were able to reduce readmissions by 13%, which is really exciting. And then we decreased the cost of doing that work by over 33%, less than the prior slide, but we're doing a little bit more than we would do in a traditional. For example, we're collecting patient satisfaction scores here, and so there's an additional cost. We've had over 30,000 students apply without even trying. And I think it's because the work's remote and pays well and it builds a resume. Here's kind of a breakdown, but you can see, nursing is the largest, but some pretty big other buckets. We also get a lot of like public health, hospital administration. So like non-clinical students are interested in this experience. And we're trying to find new ways to engage those students as well. And I think this is our last slide here, but this is one of our students. He was part of and still is part of a medication adherence program. And you could see this quote here if you want to read it. In general, we have a 91% NPS score across all of our students. And so we're really proud of that. I think we're really doing well by them. This isn't like taking advantage or anything like that. They really do find an incredible amount of value here. And that just feels good. I'm glad that that's the case. And this actually trickled up from 90 to 91. Where they see the biggest asset to their career, huge increase in confidence, huge increase in the skill that they're performing because they're doing so many times, like hundreds and hundreds of times. And given the opportunity, that score really close to reflects the NPS score. So with that, would love to take questions from the group. If there are any. You can also, by the way, go to the docs tab here and download our one pager in case that's interesting to you or anybody on your team. No questions? All right, I'll tell you how we got our name. How about that? So, thank you. So when we started off, we thought we were actually going to be doing senior isolation and loneliness. We were going to have nursing students doing Zoom calls with folks. And this was, we started in 2022. There was all these statistics around, 1 in 4 people over the age of 65 are living in isolation and loneliness. It's the equivalent of smoking a pack of cigarettes a day. And we're like, oh my gosh, we got to address this. And so we did a pilot, our own kind of pilot. We found our own isolated seniors and we found our own nursing students, and they used our very early version of our software. And it was great. Everybody loved it. The students had fun with it. They called the same patient every week. They socialize, they collect data, and did all that. And so when we think about a healthy, happy, independent senior living their best life, they're eating a grapefruit in the Sunlit Kitchen in Florida. And so Grapefruit, right? Grapefruit Health. Cost. What does cost look like? We typically charge $2 per call attempt. In that call attempt, we do data hygiene. We pre-text the patient. We say, hey, we're about to call you about this thing. We're collecting a bunch of other data points, and then we reach out to them. And if they don't want to talk, or they say call back later, et cetera, it's the $2. And then if we have a successful outcome, meaning we go through medication adherence and we sign them up for mail order drugs, or we sign them up for a 90 to 100-day prescription, or maybe they need a med rec with a pharmacist, we schedule that. That's just $5. That's typically our cost. We're very transparent about that. Do you have any proprietary messaging platform? It's our platform. The messaging is ours. We've built scripts now for the last 3.5 years in partnership with our clients and other folks, along with some AI suggestions, et cetera. And those are our scripts. We modify and iterate on them to get the best conversion rates. Automation is involved in certain areas, but not in the patient outreach side of things. We want to keep healthcare human for now. I think AI will be coming around. For example, we're developing AI patients, artificial intelligent patients, to onboard students faster so they can actually train with artificial intelligence patients. Google invested in us to build that. And so we'll have a prototype on the 29th of this month, which we're really excited about. And what does the work look like? Yeah, it's telephonic engagement. So students using our software to call, they're not calling from a cell phone or something, but they're using our software, click this, they call the patient, and they have these interactions, and they're really special. Something we do as a team, we pick one out every week to listen to as a group. Many times they go 20, 30 minutes and people are talking about their kids and grandkids and things. It's great. And because we charge on a per interaction basis, it's not like hurry up, get them off the phone. The students make between $18 and $25 an hour. You might be like, well, how is that cheaper than a $20 worker? It's because they're not the amount of attempts and the way we work with, like, we're not doing benefits and PTO, and these are the students who act as contractors. There's no technology, there's no retention. So when you look at full HR, and we had a client confirm this for us. So this isn't our math, this is their math. It goes towards that. And again, we're just doing care gap closure. If you compare us to a nurse is doing a million other things, and then maybe at the end of the day is also doing post-discharge follow-up. But we're just doing the thing so that those clinicians can level up. And so we're taking those low acuity tests on. Okay, I think we're really close to time here. Happy to take one more question or so, but yeah, for sure, Emily. Please check out our website, www.grapefruit.health. We're one of the few .health domains. We really thought that was going to take off in the beginning. I don't think many people went with .health, but we're .health. So check us out. If you're a student listening, feel free to apply on there. The location is not restricted for students. We do require today, for better or for worse, that you're a onshore U.S. citizen. Some of that has to just do with our contracts with the large payers. They have a lot of restrictions on us as a vendor. But there's no reason why you shouldn't still apply. There's other learning opportunities and partners, and we have these really engaging newsletters with other jobs and opportunities, and resume building tips and all these kind of things. And so, but beyond that, you could be in Chicago calling patients in California. We do, if the client asks us, like in upstate New York, we do recruit locally for that client because their patients are all locally. But if we're supporting a large national payer, et cetera, then the students are spread out to reflect the population. Sure. Yeah. And again, if in the docs folder here at the top, if you want to download the one pager, feel free to do so. Please connect with me on LinkedIn. Would love to stay in touch with everybody on here. And I think with that, enjoy the rest of the conference. Thanks for your time.